Hey, I think we will get started. I just want to remind, well, some of you have not been here before, so pardon me if I repeat my 30-second introduction as to why we are showing the most famous architectural structure in the world as the logo for this course. It's the Brooklyn Bridge. And life was never the same on either side after it was built. And it's a very good, you can wax eloquent with all sorts of analogies to the problems that exist between bridging the incredible advances in modern sciences and human health. And there's a gigantic gap which gets bigger and bigger and bigger as the accelerated pace of information takes place and new ideas and new concepts, and it's just a communication barrier. And for young people, particularly those who are just finishing their postdoctoral training, for example, there's a great deal of interest, has been through the years. It's why we're in the 11th year of this. There's been a great deal of interest in learning something about the major health problems, but not as for a medical audience, but more from the standpoint of facilitating communication. And I can tell you there have been many examples where postdocs have established collaborations. There are several I can think of where they actually changed laboratories, and all sorts of good things have happened, and that's the point of it. Okay, now it's been pretty successful. There are between 200 and 400 people in NIH who watch this live. And I mention that because when you ask a question, if you would just pause for a few seconds and give somebody a chance to get a microphone to you, because I keep getting emails saying the answers are wonderful, but what were the questions? So, we can always have you repeat the questions if you have. The other thing is we've always been very grateful to patients who have come and been willing to spend a few minutes describing what their disease is like to them. And as one student put it eloquently about 10 years ago, it puts a human face on a disease. And you don't have to be a physician to have empathy or understanding and feeling. It's just you use different tools. That's all. So each of the topics that we pick, which come many of them from your suggestions, we take advantage of the unique facilities and staff here, mainly at the NIH, where there's this enormous wealth of clinical investigators and basic scientists. And what we do here is like what grand medical rounds used to be, but is no more. A live patient, a physician who talks about the disease and epidemiology and things which you don't have to have a vast background. You don't have to take 20 courses in genetics or cell biology, hopefully, to get the message, because nobody's going to quiz you on the absolute contents. It's more the idea and the excitement that it may generate, which may stimulate you to read and learn more, which, believe it or not, happens with considerable frequency. I would also mention that on the website, Google Demystifying Medicine 2013, and you can go back for 11 years if you want, are all of the programs, all the PowerPoints, all the descriptive materials, some of which I try to put in each week, the CVs, abbreviated, of the speakers and their contact information, and some key references, including review articles and a few state-of-the-art things. So this sort of brings things, up to where the cutting edge is. And so through the years, we've really profited enormously by hearing incredibly exciting things that are on the burner, in the burner, coming down the pike, and how they influence these major pathobiologic questions. And it's really been spectacular. So we hope that those of you who haven't been here before will come back next week is the topic that influences everybody. It's called aging. Anyway, you can see the whole program that's there. Now, okay. So this, of course, is the famous painting by Walitt called The Scream. And I was interested in reading a long time ago when somebody wrote a biography of him, and they said, you know, what is this? What does this mean? And his answer was that this person is in pain. Well, that's not the way usually people think of this painting. They think it's just somebody who's had enough and is, you know, letting it all hang out. But it's a pretty good illustration of the point that we will hear about, and I'd just like to make by way of introduction, that pain is one of those deep challenges of physiology and of disease. Probably from the beginning of first descriptions of mammals. And it's one of the great mysteries, along with things like sleep, consciousness. And most of those things were discussed descriptively through the ages. And then with neurology and neuroscience, they were discussed on the basis of clinical observations, patients who had unusual phenotypes, neurophysiologic experiments where part of the brain was removed or stimulated, but it was still at a great distance. And of course the brain is at great distance from where we are. But of course what's happened in the more modern era is that all kinds of struts of a bridge have been put up, and the bridge is far from complete as you're here. But now some of the mystery, at least, of the big questions, could you flip the next one? So these are the ones that, you know, just pop into one's head. You have your own questions. When we put this program together, these were some of the things I was thinking of. You know, really, what causes pain? What is pain? You feel it, but how do you describe it? You'll see in this literature there are like 100 words used to describe it. But is it subjective? Can you really measure it? Can it be seen? Can you image pain? We're going to hear about that. Does pain have value? Fever has value. Fever does some positive things. And possibly that's how it all evolved. Does pain have value? And I guess you have to wonder whether there are other life forms. I'm not talking about extraterrestrial ones, but other life forms, do they experience pain? When does pain enter into the phylogenetic system of things? And as a boy, when I did nasty things to worms, was I really experimenting with pain but not knowing it? How good are we alleviating pain? That's a very complicated question, which we're going to hear a great deal about. Do you tolerate pain? Is there such a thing as tolerance in the same way as you can become tolerant to a drug? I mean, these, I guess they're largely Indian chaps who put a hook through their arm, you know, and are hung up. Do they experience pain? Or maybe they have some disease that takes the pain away. I have no idea. But these are just one of a myriad of questions which I hope are bouncing around in your minds as well. And so we now can turn to our guests. And we're very fortunate to have two colleagues who are expert in the dimensions of this pain spectrum. So our first speaker is going to be Brian Walitt, who received his medical degree at State University of New York at Syracuse, and then subsequently training in rheumatology at Georgetown and at George Washington. And at present, he's associate professor of medicine at Georgetown and research director of the Division of Rheumatology at the Washington Hospital Center. And if you look in his CV and you'll so forth, you'll see that he has directed enormous attention to the clinical and pathological aspects of pain and its amelioration. Now, our second speaker is Catherine Bushnell, who was recently appointed to direct a new state-of-the-art program here, which is the focus of the NCCAM's intramural research. That's the alternative medicine branch. And this research is focused on the brain's role in perceiving, modifying, and managing pain. So Catherine is the coordinator as well as the prime investigator in this. She received her PhD in experimental psychology from American University and was professor of anesthesia and dentistry at McGill. And her work has been in bridging particularly imaging technology into major questions dealing with these issues of pain. Pathways, communication, how does it happen, how do we deal with it? And without understanding the neurobiology of pain, therapeutically, one is to a considerable extent sort of shooting in the dark, just dealing with symptoms in the same way as you might treat fever with aspirin or Tylenol without knowing that you had pneumonia. So, and Bruce, Brian, would you please
Thank you.
begin and introduce your patient?
You guys hear me all right? Good. Well, hi there, everybody. I'm Brian Walitt. Our talk here is Demystifying Medicine, pain, how it happens, and what can we do about it. I don't have any financial conflicts to report to you at this time. So, I think this is a familiar face to all of us. I don't think it takes anybody more than a second to recognize what he's trying to express, which is the experience of pain. The experience of pain is something that we have all shared many times over the course of our lives, and probably have made this kind of grimace on our own without being able to control it. Pain is an essential part of most humans' lives. Pain is very important in structuring a human life. It does have value. It teaches us the boundaries of our existence. We know when we have pain that we're overstepping our bounds and putting ourselves into a potential situation where we're injured. Pain is an amazing motivator. You put your hand on a stove and your hand is off that stove before you can even think about it because of the sensation of pain. Pain shapes our behavior. We all spend a considerable amount of time trying not to get hurt in our daily lives. And we don't appreciate that all the time, but pain shapes who we are and much of our human experience. Currently, we try to define pain in these sort of words here as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. However, you quickly realize that this really doesn't capture any of the essence of pain. The experience of pain does not translate well into words. What you feel cannot really be expressed to another. Pain is also a very private experience. When you have pain, you cannot share that with another. The experience of pain is your own. The best that one can do is try to explain how you feel or show with body language and hope that others will take your pain and appreciate it. But nobody can really share another person's pain. When you see a man like this who fell off his bicycle, you can truly appreciate that he's hurting. His body language is telling us he's hurting, and the situation that took place, him falling off his bicycle, suggests injury. We feel very comfortable from our own experiences that if we have some sort of trauma or injury, that it's going to hurt. And this type of pain is nociceptive pain, one that comes from the causality that we all know. Injury leads to pain. In medicine, though, this is not such a big problem. When people have nociceptive pain, there are medicines that we can use. People have great experience using non-steroidal anti-inflammatory agents, medications like morphine and other opiates, with good success in treating sort of the pain of trauma. And this is sort of just part of the medical spectrum of pain. The true problems with pain, though, come from people like Melissa, who we actually sitting with us today and will be interviewing later. When you look at Melissa, she looks normal. Nothing in her expression is telling you that she has pain. If you were to examine her from top to bottom, there would be no sign of trauma or injury. If you were to take blood or put her in an MRI machine, there would be no signs that there would be any reason for her to have pain. But as we'll find out later, that's not her experience. In fact, Melissa has a condition called fibromyalgia, in which she has chronic pains that go throughout her body and don't really have a clear cause and can't be shown or proven outside of what she tells us. And these kinds of pains, the types of pains that occur with a discordance from what we see on the outside, we call functional pain, right? Functional pain is when the pain experience doesn't match up with the experience of the body as we see it. And it turns out that the bulk of medical problems with pain are actually functional pain problems, that this is the great challenge of pain for medicine in our modern day. And it turns out that there are lots of different functional pain problems. Two of them, the most common ones, we've all probably experienced, which are low back pain and headaches. Low back pain is one of the most common of pain problems. 85% of people will suffer low back pain at some point in their life. Not forever, but for a period of time. 2.5% of all medical visits currently are for the evaluation and treatment of low back pain. That's 15 million visits a year. We spend $100 billion in the diagnosis and treatment of low back pain. And it turns out about 75% of those dollars are spent for about 5% of patients whose symptoms are so severe and so chronic that we consider them to have chronic disabling low back pain. Headaches are also something that all of us have experienced at one point in time, but it turns out around 38% of people have headaches more than once a month, with about 2% of the population having such chronic headaches that they require medicalization. These are very common problems. Again, being functional, there is nothing when you examine the low back or the head that would suggest a reason for the pains that are being experienced. It turns out that other disorders are also very common of pain that have a functional component. Osteoarthritis is another one of the more common pain problems in our society, which is responsible for about 11 million office visits with an expense of about $186 billion a year. Typically, people think of osteoarthritis as a nociceptive pain disorder. Here, what you see is a normal knee, and people tend to think about osteoarthritis as a wear and tear disorder that comes with aging and use of a joint, where you lose the space of a joint and you develop spurs on the outside that create injury, which then create pain. And so for many years, it was thought that osteoarthritis was a nociceptive pain problem caused by injury. But what we've learned is that there's more aspects to it. In fact, there is a functional aspect to osteoarthritis, and this is what this table is trying to show. On here on the y-axis, you're looking at the prevalence of pain, and on the x-axis, we're looking at the radiographic grade, or the severity of injury, where 0 to 1 is not injured or barely injured, and while 3 to 4 are people who have severe osteoarthritis. And what you quickly realize here is that people who have very little evidence of injury, about 1/5 of them will report significant pain that makes them seek medical care. Conversely, in people that have severe injury, not all of them suffer from pain. Only about half of the people, half of men and up to about 80% of women with severe injury will actually mention that that injury causes them pain. So in osteoarthritis, there's a growing appreciation for the discordance between the injury and the painful experience, suggesting that perhaps osteoarthritis is also a functional pain disorder. Pain doesn't just have to be in the body, in the muscles or the joints, but it can also be in the viscera and organs of a body. And this is irritable bowel syndrome, which is a good example of this. Again, extremely common, affecting 10 to 15% of the population of the U.S. It comprises about a quarter of all consultations to gastroenterology. A fourth of what gastroenterologists do is irritable bowel syndrome. And the symptoms are very bothersome. People have incredible discomfort of their abdomen. They feel distended and bloated. They have intermittent and alternating diarrhea with constipation. And these symptoms can get so severe that they become disabling for some people. We think that this costs around $30 billion a year to our society to try to take care of people with these symptoms. And lastly, we talk about what is of my greatest interest, which is fibromyalgia, which is estimated to affect about 4% of the population of America, with an estimated cost of between $12 and $14 billion a year. Fibromyalgia is in some ways the quintessential functional pain disorder, at least was initially characterized that way, where people have pain with no cause when you look at them, no good reason to have the pain that they're experiencing. And these pains are not trivial. Up to a quarter of people with fibromyalgia are disabled because of the painful experiences that they have. And so we'll be talking a little bit more about fibromyalgia, and so it's good to just go through the definition with you. In at least the original definition in 1990, this research idea came out, which defined fibromyalgia as a prototypical pain disorder, the quintessential functional disorder, where people who had no obvious cause of pain, that had pain for more than 3 months in all 4 quadrants of the body, and tenderness in 11 of 18 points, sort of arbitrarily determined, would qualify you for fibromyalgia. Quickly, when you look at this definition, you realize that it has no physiological meaning. This is just a description of symptoms. But this became the de facto definition for about 20 years. Looking at the whole of functional pain disorders, you realize that they sort of go on and on. Right? So it's not just what I mentioned, but there's a wide array of these things, from interstitial cystitis to endometriosis, from vulvodynia, costochondritis, temporal mandibular disorder, myofascial pain disorders, and even some functional aspects have been recently discovered in inflammatory arthritis, such as rheumatoid arthritis, where again we see this discordance between the amount of inflammation and the amount of pain that people experience. And so when we look at all these together, we have to wonder, can all this discordance, all these functional pain disorders, do they really have something in common? Right? Is there a common biology, a common neurologic biology within the brain that binds these together as one great group, one entity that may be amenable to some sort of solution? If there is a meaningful biology that binds them together, are there particular factors we can discover that influence how this biology works? And if we understand the biology, can we intervene in a meaningful way to provide relief to these patients? Hopefully we're going to get at some of this today. I'm going to leave you with this, and I'm going to turn the podium over to Catherine Bushnell.
Can you hear me now? Okay. So anyway, thank you very much for this introduction to really what pain is. And I'm going to try to give you kind of a whirlwind view of the neurobiology of pain. So in the next 45 minutes or so, I will cover a lot of territory. I'll try to keep it understandable, and hopefully we can then get back. Then we're going to go back to Brian, and who will be interviewing the patient, Melissa, and after you have a little bit of understanding of what could be the mechanisms underlying these various pain conditions. Okay, so as Brian has pointed out, and as Wen pointed out earlier, that pain is a very complex sensory and emotional experience. And there are people like the guy on the left who's like my daughter when she has a headache. And then there are people like this man on the right who can hang himself from meat hooks and look to be perfectly comfortable. And there are a lot of reasons why we express pain differently and why we feel pain differently. And the expression of pain is somewhat different than feeling pain, because there are even cultural differences in the way people express pain independent of what they feel. For example, there's this pain questionnaire that was developed by Ron Melzack at McGill University called the McGill Pain Questionnaire that's been translated into like 15 different languages. And it was actually translated into Bedouin. And there were these Bedouin women that when they have childbirth, they don't really show any signs of pain. But when he gave them this McGill Pain Questionnaire, which they filled out anonymously, they in fact were feeling pain the same as the Italian women. They were screaming and hollering. So there is a cultural difference in expression that may be different than our processing, but there's more and more evidence that the way we process pain is highly variable. And there's a growing literature on how genetics can influence pain, but there's also many environmental and psychological influences that I'll show you can endogenously activate pain modulatory systems in the brain, so that the same systems that are activated when we give people analgesic drugs can be activated naturally through psychological or environmental processes. So as Brian has already pointed out, I'll just reiterate here, there are different types of pain. What we call nociceptive pain is protective. That when you put your hand on a hot stove, it's adaptive to take it off as quickly as possible. And there actually are people that are born that have a congenital defect where they lack these primary afferent C fibers that are important for pain transmission. And these people that have this congenital insensitivity to pain, in fact, many of them don't live to be adults because, well, for example, if they put their hand on a hot stove, they don't know it until they smell the burning flesh. But if they have an internal injury like appendicitis, they wouldn't feel it. And even simple little things like that we use pain every moment of every day in our life, but we just don't think of it as pain. So I stand here in one position talking to you, and after a little while I shift my weight. That's really because I'm becoming uncomfortable. That uncomfortableness is really an activation of the pain system in a little way. And these kids that have the congenital insensitivity to pain, they will stay in the same position, and they have arthritis in their knees and their ankles when they're 5 years old. Or they'll just, they'll be kneeling down and they'll have they end up with pressure sores in their knees when they're kneeling to playing because they don't feel that. So it's something, this protective pain is very, very important, and we can't live without it. And as Brian also pointed out, that we think of some of this traumatic inflammatory pain as being protective. If you break your leg, you'll have an inflammatory response, and it's protective not to be walking around on that leg. But in many cases, as in arthritis, the inflammatory injury actually causes kind of a vicious cycle, and it's not protective anymore. You know you have arthritis. I know I have bad knees. I know I have bad hips. You don't have to keep telling me every moment. I've stopped running. So it's no longer. It has a healing repair, but then it can become pathological. And as it becomes pathological, as Brian was pointing out, the injury becomes dissociated. What you can see on a radiograph does not represent what the person is really feeling. And you didn't mention with back pain that again, people with back pain, if they go to a surgeon, they see there's something wrong with their back and they'll do surgery. Well, in studies where they've looked at the backs of any 50-year-old, his spine is not going to look good, and there's really little correlation between how much pain you have and what the spine looks like. And there's another type of pain that Brian didn't talk about so much, but it's becoming more and more important in our society, is neuropathic pain. And this is pain that's caused by an injury within either in the nerves or in the central nervous system. I'll show you that a little in the next slide. But this is diabetes, a diabetic neuropathy. As we are getting fatter and fatter, more of us are having diabetes, and one of the consequences of diabetes is injury of the longest nerves, and the syndrome where you have a burning feet that can be excruciating and debilitating. And even lesions within the central nervous system. After certain strokes, particularly it was first identified with what called thalamic pain syndrome, where after a stroke that involved parts of the thalamus, people would have excruciating pain. Nobody would know where it was coming from because it was actually coming from inside the brain because of the disruption of the normal pain pathways and modulatory systems. And as Brian pointed out, the most hard to explain and understand are these functional pain syndromes. At least with neuropathic pain, we know there's some injury to the nerves of the brain. Here we don't know where the injury is. So this again just shows that with the nociceptive pain, you have a clear signal, noxious signal from the periphery. In neuropathic, there's an injury, either a peripheral nerve or somewhere in the nervous system. And with the functional pain, we don't know where the injury is. So just to get a little kind of basic physiology of what's going on with pain, there are multiple transduction mechanisms at the level of the periphery. And we have different types of receptors that have been identified now, these various V1, V2, various TRP receptors that we know respond to heat. They also respond to the chemicals, a chemical called capsaicin, which is the active ingredient in hot chili peppers. So when you eat Thai food and you feel a burning sensation in your mouth, it's not really heat, right? But it feels like burning. And the reason it feels like burning is because it's the same receptors that respond to the capsaicin, the chili pepper, as respond to heat. So you perceive it as heat, even though it's not really heat. And then there are receptors that respond to acid, to mechanical stimuli, to noxious cold. And so there's been a lot of work over the last 10, 15 years identifying these various receptors and pathways and trying to develop drugs to target some of these. But unfortunately, when you try to target very, very specific channels, you find that it's not going to be knocking out, most pain is not involving just one specific channel. And these TRP-V1 antagonists that have been developed are not so useful in a real pain situation because pain is complex and your body seems to have multiple ways to get that signal to your brain. So you go from the periphery to the spinal cord, and in the spinal cord, the dorsal horn of the spinal cord, there are cells that receive this primary afferent input. There are different types of primary afferent fibers, what we call the C fibers, that are unmyelinated. They conduct very slowly, and then we have the various myelinated A delta, A beta fibers. And I mean, one thing that's interesting is because the C fibers, they conduct really slowly, like something like 1 meter a second. So if you put a knee up or burn your toe, and then that fiber has to go all the way up to your leg to your spinal cord, even in somebody short like me, that's like 1.5 meters. And it takes like 1.5 seconds to get from your toe to your back to synapse in your spinal cord. And you can actually do what they call first pain and second pain by, with something on the long nerve where you can put a little hot thing on there and you can feel this initial, it's more of a pricking sensation and then a slow burning sensation. These are two different types of nerve fibers that are transmitting the pain. And in the dorsal horn of the spinal cord, there are, I know I should be pointing over here, but this is hard. Okay. So you want me to be using this? Okay. So you have transmission, what they call transmission neurons that send axons up from the spinal cord up to the brain, and you have these in the superficial layers and the ones that are deeper. But the most important thing here is that there are also these various interneurons, and there are neurons in the brain that send synapses down to the spinal cord and that modulate the activity of the afferent. So as the information is coming from the periphery up the spinal cord up to your brain, there's other descending information that's coming down and modulating the activity even at the level of the spinal cord. And I'll show you how even psychological processes can activate these descending modulatory systems. And then there are local interneurons in the spinal cord that will modulate this activity. So there's a lot that goes on to modify the afferent pain input as it's going up to the consciousness. And there are multiple from the spinal cord. There are multiple pathways that are going from the spinal cord to the brainstem, midbrain, up to the thalamus, and then to multiple parts of the cerebral cortex. And you don't need to memorize the slide, but it just shows that there's not like a single. Descartes came up with this idea 300 years ago that there was a single pathway, and there's a one center up in the cortex that when you pull on the string on your toe, it rings the bell in your cortex, and there is a pain center. And people have tried to identify that, and over the years, people have ablated different pathways. You say, okay, I'm going to cut the spinal thalamic tract, and that helps pain for a while, but it keeps coming back because there's multiple pathways from the spinal cord up to the brain, and there's no one part of the cortex that will take out the pain. We've studied patients that had severe epilepsy where they had a complete hemispherectomy, had an entire hemisphere of their cortex taken out, and they could still feel pain on the contralateral to that. It's again, because pain is so important to our existence, our brains have adapted to have multiple processing of the signal. So brain imaging is a way that's been very useful for us to understand pain as opposed to nociception. As Wynn pointed out earlier, do worms feel pain? Well, you can take a worm and you can poke him, and he will withdraw from that. So he has a reflex, and so you can have the simplest organisms, and they will withdraw from a noxious stimulus. But do they have the conscious experience of pain? I'd say my dog has a conscious experience of pain, or at least I can anthropomorphize that he does, but we can't know. We can only, as Brian pointed out, we can only know our own pain. I can't even know if you have pain. But brain imaging is nice, and it's allowed us to be able to look inside people's brains and correlate when they say, I have pain, to look what's happening. And this, you'll see as we go through here, that people that have functional pain syndromes, you can't see where it's coming from. They say they have pain, and we look in their brain, and lo and behold, we see the same type of activity as we would see if you were burning your finger, and we would say, yes, you do have pain. So, so this has been a nice tool for us. And I just show you here that, okay, so the gray just shows an anatomical picture of the brain, of anatomical MRI, and then superimposed on top of that are colorful globs, which are just kind of color representation of statistics of showing where there is statistically more activation going on when, here you see this is, we put what we call a thermode, a stimulus on the skin where we can change the temperature, and we can use a temperature that causes a burning sensation, but when presented for short periods of time, doesn't damage the skin. So it's like, for example, when you're cooking, and you have a hot pan on the stove, and you pick it up and you carry it over to the sink, and you feel a burning sensation, and you wouldn't want to hold on to it for half an hour, but for holding on to it for 5 seconds, that's okay. This is a type of stimulus that we use. And when we do that, so using just kind of short heat pulses, something very simple, something that we all are familiar with, something that doesn't cause even a huge emotional reaction because we are familiar, and you can walk out of the experiment anytime you want. We still get activations in multiple parts of the brain. S1, primary somatosensory cortex, what we call S2, secondary somatosensory cortex, which is on the upper bank of the lateral sulcus. Anterior cingulate cortex, part of the limbic system, and the insular cortex. So parts of the emotional limbic system, as well as parts of the somatosensory system, are activated. And even though the pain is this is a discrete pain on one leg, you're getting activations of both sides of the brain in all of these areas except for the primary somatosensory cortex. That cortex kind of, it localizes where the pain is. There's a homunculus where you can see where the pain is. But the other areas, it doesn't matter where it is, you're getting this activation on both sides of the brain. Now, as I said, that we think that these different activations represent different aspects of the pain experience. And there's multiple lines of evidence. I just want to show you one type of evidence, so that we think that the somatosensory cortices are important for the pure sensation. So when you burn yourself, you feel a burning, stinging sensation, and then you have an emotional reaction to that. It hurts. And that can be, I mean, obviously, the stronger the sensation in general, the more it bothers you, the more unpleasant it is, but that's not always the case. There are cases where, for example, you go and you have a deep massage, and that massage hurts and you feel this muscle pain, but it also feels good, right? So the actual sensation can be one of deep pressure pain, but you can have a positive emotional reaction to it. Well, other cases, it could be not very intense, but maybe because of the meaning, you have, let's say you know that you have some abdominal cancer and you have a stomach ache, and you think, you know, this is not a good sign, and you can have a very strong emotional response. While you could have the same pain after you've had a wonderful gourmet meal and you attribute it to indigestion, and you don't have the same emotional response. So these can be dissociated. And what we're finding in the brain, so this is a patient that had a stroke that had a naturally occurring lesion that involved the primary somatosensory cortex and the secondary somatosensory cortex, but left these limbic areas, the cingulate cortex, the insular cortex, intact. And what the researchers did is they then blindfolded the person, and then they would pinch and poke and brush his skin and do various things on different parts of his body. And he couldn't, because he had lost this somatosensory cortex, he couldn't localize what was happening, and he couldn't even tell you exactly the quality. He couldn't tell if it was a burning or a cold, but what he could tell you is that he didn't like it. So when he did something that should have been painful, he goes, I don't like that. If he did something that was nice, like brushing the skin, he'd say, I like that. And so that he had this pain affect, we call it pain affect, without having a clear sensation. So it looks like these different parts of the brain are important for different aspects of the complex experience. So this whole network that we see, we do find that it's activated with multiple types of pain, whether you cut yourself or you have back pain or arthritis or various types of pain. And so there does seem to be a lot of commonalities, even though these pains are different. When you describe arthritis in a knee, it's not the same experience as cutting yourself. But we have this construct, pain, and we all know what it is. And I think what it is what's happening when this whole network is activated, even though there are a lot of differences that can be represented in the brain as well. There's a common central pathway that says, okay, this is pain. So, as I said, that pain is a constant interaction between this afferent flow from the periphery signaling bad things are happening and descending systems, modulatory systems, that can either be enhancing or dampening the afferent signal. So these descending modulatory pathways start up in the cortex, and there are multiple ones that many of them involve the prefrontal cortex, and then they go down in these midbrain areas, this area called the periaqueductal gray matter, PAG, which has been identified about 30 years ago and has been studied a lot, as being very important for descending modulation of pain. And you can inject opiates into there, and you can have a profound analgesia. Or you can just stimulate electrically this area in a rat, and you can do surgery on the rat, and he'll just lie there and not show any pain behavior. It seems to be a very important part of this descending modulatory pathway. But the information that gets there starts up in the cortex and then works its way down. And when you get down to these lower areas where people have studied a lot in more animal models, we see that there are multiple neurotransmitters that are involved, and you have multiple cells and multiple pathways through this system, and at some of the time the descending system can be facilitatory. It can enhance the afferent signal. Other cases, it's inhibitory. It can dampen the afferent signal. And there's various neurotransmitters involved. And what I want to point out is that on the inhibitory side, there are a lot of these things that, well, Brian will talk to you later, that are involved, that are used as analgesics. The opiates, there are what we call the SNRIs that involve both serotonin and norepinephrine reuptake inhibitors that are used as antidepressants, but they can also have a direct effect on pain through these pathways. Serotonin works on both sides, so the SSRIs, which are the most commonly used antidepressants, have not been shown to be very good for pain. I'm not sure if the SNRIs, but at least Brian will go into, but there's more evidence that they are good for pain. And it may be this balance between do they facilitate or do they inhibit on these modulatory circuits. And so it's these central pathways, if you look here at this bigger picture of how all these various analgesics, pain relievers that are out there, how they may act within these pathways in the brain and activate these modulatory systems. So even things like NSAIDs, the non-steroidal anti-inflammatory drugs that are used like aspirin or ibuprofen and all of the ones that are all these over-the-counter drugs that we take to reduce inflammation, they even have some central effects in this system. Cannabinoids, there are people now who they've shown that the cannabinoids or smoking pot can help chronic pain conditions, and they act in some of these systems as well. And then there are these ones like the SNRIs, the tricyclic antidepressants, and there are anti-epileptic drugs like gabapentin or pregabalin that are these alpha-2 agonists that act in these systems as well as opiates, and opiates act in multiple parts of the brain. So the various drugs we take work because they activate systems in the brain, unless they're peripherally acting and changing inflammation in the periphery. But these systems are not there so we can take drugs, right? I mean, they didn't evolve so we can take drugs. So how are they activated naturally? And this is how psychological factors we're finding are very important for activating these descending modulatory systems. And so two kind of dimensions of psychological factors are emotions, and the other is attention and distraction, your attentional focus. And this is something that we've studied in our lab and found that, in fact, these are very important. They change pain. This is the virtual reality, these virtual reality glasses, which is a big distractor, and emotional state and love and compassion and empathy all have an effect on these pathways. So what happens here? Attention is very, very simple. Distraction. So you see this in your everyday life that reading a good book, you don't think about this, but you're sitting there reading a good book and it's great and you're really focused on it, and then you take a break and you realize you've been hunched over in a funny position and your shoulders hurt, your neck hurts, but you didn't feel that until you stopped because you were so distracted with what you were doing that you really didn't feel the pain. And it's actually quite a profound analgesia. It seems trivial, but it's not trivial, and we find that you can get effects with distraction that are similar to giving somebody an opiate. If we, in the experimental situation, we can present a painful heat stimulation, and we can either have the person paying attention, I think I'll go to this, paying attention to the pain, or we can present another stimulus, in this case an auditory stimulus, and have them distracted because they have to do a task where they pay attention to the other stimulus. Oops. And what we find is that when you ask the people to measure how strong the sensation is and how unpleasant it is, that in fact you get this reduction, and really a more profound reduction in how intense they feel the pain with a less strong effect on how much it bothers them. And so in these types of experiments that we've done a number of times in our lab, we find that distracting from somebody from the pain alters the pain differently than changing their emotional state. So you can do things where you change the person's emotional state. You can do something to put them in a good mood or put them in a bad mood. And when you do that, you can also change their pain. But when you are changing their pain by distracting them, you're mainly altering how intense they perceive the sensation, as you can see over here, and less so in terms of how unpleasant they find it. But when you change their pain by altering their emotional state, so you put them in a good mood or a bad mood, you're not changing their perception of how strong the pain is. You're changing how much the pain bothers them, how unpleasant it is. So you're really changing two dimensions of pain. And as I said earlier, there's different parts of the brain that are signaling these different aspects of the pain experience. And what we find is that, in fact, using distraction or using emotions engages different modulatory systems in the brain to alter the pain. So here, this is primary somatosensory cortex, the somatosensory area, and this bright spot shows that when you give somebody a pain, it's a heat pain, you're getting a nice activation in this area. Now, you distract them and you give them the exact same pain, and you can see by this less bright spot that represents less neuronal activation, and so that you're getting a stronger signal when you're focusing on the pain than when you're distracted from the pain. And this is something I think is important that, like a chronic pain patient, can learn to use this and learn to not feel guilty about doing things that distract them or make them feel good, because in fact you're really changing the physiology of the brain. Now, emotions also alter this signal, the pain signal in the brain, but they do it in a different part of the brain. You're finding here that altering a person's mood state doesn't alter the activity in the somatosensory system. It alters the activity in this limbic system in the cingulate cortex. And again, on the left, you see that when you give a person a pain when he's in a bad mood, you get a nice activation. You give the exact same stimulus when he's in a good mood, and we don't even reach statistical significance there, so we're not seeing a spot. So you can have a profound effect on this activation with these naturally occurring psychological factors. So this just shows you that I can't go into all the details, but we've shown that there are two different modulatory pathways that are involved with these different types of naturally occurring dampening of a pain signal, or enhancing, which way you look at it. Okay, so this brings me to placebo, the placebo effect. When people have a response to a placebo pill, you get a pill, it's an inert pill, it's a sugar pill, you take it, doctor says this is going to make you feel good, feel better and make your pain go away, and it makes your pain go away. Your first reaction is that person, well, first of all, was just making it up, or, he's crazy, or he doesn't know what he's talking about. But in fact, that's not true. Placebo analgesia taps into naturally occurring systems in the brain, such as I just described. And there's been several studies, this one done by Tor Vager and his group in Colorado, that they did a study, a brain imaging study, where they were examining placebo analgesia, and they had an anticipation period where they told a person that they're giving an analgesic, and they expected to get pain relief, and then another situation where they're not expecting pain relief, and then they give the pain stimulus, and when they give the pain stimulus, you get the whole network activated that I've shown you before. But the important point is that these red globs show regions where, when the person is experiencing placebo analgesia, feeling less pain because they've gotten a placebo treatment that makes them think that they're getting less pain, in fact, their brain is telling them that they're getting less pain. So these areas, parts of this nociceptive system, the red globs show areas where there's significantly less activity when the person is experiencing the placebo analgesia than when he's not. So there's a real physiological basis. The signal is really being dampened. And we now know that part of this dorsolateral prefrontal cortex and midbrain PAG are involved in this placebo analgesia. So again, this pathway that I showed before that's important for emotional modulation of pain also is important for placebo modulation of pain. And there's some other studies, and they're kind of complicated, where you radio label a drug, and you can see where it's taken up in the brain. You can see how it's modified during placebo. But the bottom line is that we're seeing that, in fact, that when a person is experiencing placebo analgesia, they are releasing opiates in their brain, in parts of the brain that are important for analgesia. So you are naturally releasing the drugs that people give you, exogenously to treat your pain, that through your own psychological state, you release these neurotransmitters in the brain. And so opiates are released and dopamine are released during placebo analgesia. So all I have to say is a real physiological and neurochemical basis. So something real is happening, and it's not that a person is making it up, malingering, or crazy. It's real physiology. So Brian also talked about the experience of a chronic pain patient, and even how the person's expression of pain is different than when you have acute pain. So the picture that Brian first showed of the guy with the grimace, that's what happens. That's a grimace is what you see when somebody has an acute pain. You've just broken your wrist, and you're like this. But when people with chronic pain, their facial expression can be, this is Frida Kahlo, who is a Mexican artist. She was in a bus accident when she was a teenager, and she suffered from chronic pain her entire life. And I think this is a beautiful picture because it shows her, it's a self-portrait of her pain. And you see that as many people with chronic pain, they come into the doctor, they say, it feels like somebody is driving nails into my arm or my feet are on fire. But the person is sitting there, you think, if my feet are on fire, I'd be screaming. They're not screaming. They have a normal facial expression, because when you have chronic pain, it becomes quite dissociated from your expression of the pain becomes associated from what you would think of with acute pain. And we actually see the same thing in our rats, that there's been this question when you have these various models of nerve injury, and the rats are hypersensitive to having you touch their paw, but they run around, they eat, they have normal behavior, and you think, well, they don't have any chronic pain, they just have this hypersensitivity when you do specific things. But when we've imaged their brains, we're seeing an activity pattern of pain, even though they're not having the expressions either. So it really seems to be a common thing. But this idea that, in fact, that you have that, without having any obvious damage, you have this experience that is highly excruciating. But what we see in the brain when we look at patients is that, in fact, we're seeing activations that are consistent with what they report. So a mechanism that has been attributed to the fact that people have pain without the obvious insult going on is called central sensitization. It's a pretty vague term, and it was defined by Clifford Wolf 25 years ago as an increase in the excitability of the central nervous system so that normal inputs now evoke exaggerated responses. So it can mean anything, but it's just that you have this exaggerated response in your brain, so that, and there's a phenomenon called allodynia, meaning that something that it usually applies to light touch, so that when you can lightly brush the skin, that should feel good, but somebody after certain nerve injuries, that can provoke a terrible burning pain. So when light touch is evoking pain, they call it allodynia. And it's attributed to this idea of central sensitization. But what is central sensitization? I mean, this doesn't really mean very much. Well, people have looked at mechanisms mainly in the spinal cord in animal studies, but it's thought that maybe some of these same mechanisms can apply throughout the neuraxis. But there seems to be a number, not just one mechanism, but a number of things that can cause central sensitization. One is you can have direct activation of certain receptors that are important for pain. You can have decreased inhibition, where I told you how you've got these inhibitory systems coming down. If that is disrupted, so you have less inhibition, then that's going to change the balance and have an increased signal. There's a whole area of study now about neuroinflammation and how there's a whole bunch of cells in the brain that are not neurons that people used to think were just, there to hold the neurons, just structural. And they're microglia and astrocytes. And now we know they're very important for neuroinflammation and the interactions between these, a nociceptive signal can lead to the activation of these cells and have interactions with neurons. So it's a whole area of study that's becoming very important for pain research. And then there can be intracellular change, gene expression within the neurons in this system. And also we can have a synaptic plasticity, so there's a reorganization. If you lose one input, then cells can synapse with cells that were not, that they didn't normally synapse with, so that you can get an altered input into something, to a cell that's supposed to be transmitting pain. And this can happen even in the adult. It's not only during development that you can have this type of plasticity. And then, as I said, this then can happen in the spinal cord, and it can happen in other parts of the brain. So this is going to be kind of busy, but I just would say that there's all these intracellular mechanisms. This kind of maybe I just won't even go into all this, but this is a little bit more basic in that these changes in synaptic connectivity that have been demonstrated are showing that normally you have these non-myelinated fibers that transmit pain, and then you have these myelinated fibers that non-nociceptive fibers that don't normally synapse with the pain transmission neurons, and that when you have, after nerve damage, some of these can now start synapsing with pain transmission neurons that they would not have synapsed with before. So now information that should be about light touch is going to the wrong transmission neurons. And this loss of inhibition, which it's been shown in the spinal cord, but I think it's very important throughout the brain, that if you're losing either an inhibitory interneuron or a descending modulatory inhibitory neuron, that the balance between the excitatory and inhibitory activity changes. And this, I think, is a very, very important part and probably in many of these functional pain syndromes, that the inhibitory systems are altered in the brain. Again, this immune and glial cell reactions, and I don't think I want to go into all the details, but again, you're getting activation of these immune cells that are going to interact with neurons and alter the activation patterns of the neurons. So it's been mainly studied in animals in the spinal cord, but there's more and more evidence that similar types of mechanisms can be happening at supraspinal levels as well as at the spinal cord. So this central sensitization with the multiple mechanisms, and based on one or others or multiple of the mechanisms, could lead to this kind of enhanced pain processing in chronic pain disorders. And if you look using brain imaging, as I said, you actually see this reflected in the brain. Now this is an example of somebody who has brush allodynia. This is somebody who had a nerve injury due to ischemia, where she had a zone on the top of her foot where lightly brushing it caused excruciating pain. And then when we scanned her brain and compared brushing her healthy foot, which that felt good, versus brushing the foot that was damaged that had the allodynia, we see many differences in the activation patterns in the brain. We see enhanced activation in the secondary somatosensory cortex, and we see activations in these limbic areas. On the left, with the red circle, shows activation in the anterior anterior insular cortex that you don't see. You only see that normally you see with pain, but not touch, and you're seeing this with touching the damaged foot and not the healthy foot, and in the anterior cingulate cortex in patterns that you only normally see with pain, you're seeing now with light brush after the nerve damage. So it's just saying that when she says that she feels a burning pain, if you look at the pattern in the brain, it represents the same thing. Now fibromyalgia, this is a biggie, because for many years people thought, it's mainly middle-aged women, it's the same as hysteria, just whatever. Well, people with fibromyalgia are hypersensitive. It's been characterized clinically by this hypersensitivity to pressure at certain points. But the data now show that people with fibromyalgia are hypersensitive to lots of different things: pressure pain, heat pain, We've done it with injection of hypertonic saline into a muscle. They're also hypersensitive to noxious auditory stimuli and to noxious odors. So, and more so to noxious stimuli than non-noxious stimuli in other modalities. So it's a very widespread hypersensitive syndrome. And this is work done by, were you on this study? You're not on this study. Okay, by Rick Gracely, a collaborator of Brian's. Okay, so what they did is they did a pressure stimulus, but they didn't use one of these pressure points. They used pressure on just the thumbnail, like shown there. So it's not a normal tender point. But the people that had fibromyalgia, there was a pressure that the experimenters found that the healthy people said that doesn't hurt, it just feels like pressure. But the exact same pressure for all the people with fibromyalgia said that hurts. And when they did then image what the brain was showing with that pressure stimulus, these red dot blobs show regions where there was significantly more activation for the fibromyalgia patients than for the matched healthy controls. All through this whole pain system in the brain is showing this enhanced activation with a very simple pressure stimulus when people have fibromyalgia. And this general concept has now been replicated in a number of studies showing that when fibromyalgia patients say that hurts, the brain is telling them that that hurts. And so this idea of central sensitization has now been applied to a number of chronic pain syndromes. I guess Brian will talk more about that he's already mentioned, including migraine and even things like chronic fatigue and irritable bowel syndrome, and things that are not pain syndromes, but the same concept can apply to PTSD, but then things like temporal mandibular pain, other pain syndrome, but then again, other syndromes, that restless leg syndrome, that are non-pain syndromes and pain syndromes that all have this common hyperexcitability to them. Another thing that we're finding with chronic pain patients that may be contributing to the sensitization is that we're finding anatomical changes in the brain, particularly in regions that we think are important for this descending modulatory control. That we are in fact finding that if you look at the gray matter of the brain where the cell bodies of neurons reside, that we get a reduction in the gray matter in chronic pain patients compared to healthy controls. And I said particularly in areas where we think are important for descending modulatory control, suggesting that maybe the anatomical changes are contributing to some functional changes in these regions. So this was first described in 2004 by Vanya Apkari and his group, that he had, if you look, he just was plotting here on the left an total gray matter in the brain, and he had control subjects. He had two types of back pain patients, one that had back pain confined to the back, and others that had what they thought of as a neuropathic component, in that the pain radiated down their legs like sciatica or something that seemed to have some nerve involvement. And if you look at the gray matter over in A, the healthy people that are matched on every other thing they could think of had the most gray matter, followed by the back pain patients that didn't have the the nerve component to it, and then followed by the ones that had the more widespread pain that had nerve involvement. So, but if you look at the part of the brain most involved, this part, the dorsolateral prefrontal cortex, which is part of that descending modulatory control system that we know is involved in pain modulation. So it suggests that some chronic pain is not good for you. Similar has been now a bunch of these studies. This is just an example from tension-type headache, fibromyalgia from our group. All the chronic pain syndromes now, you see the same thing. And it's actually not only chronic pain, some of the other chronic disorders, such as some of the chronic mood-related disorders like depression, also it's not always the same parts of the brain with these other disorders, but you also see changes in gray matter with depression that correlate with the more loss in gray matter, the worse the depressive symptoms. So a lot of chronic pain disorders, PTSD, that we see these changes in the brain, anatomical changes in the brain. And even, this is even showing interactions between depressed patients and and pain systems. Here's a study with people with major depressive disorder showing that, let me go back here so I can, okay, I'm going to have to do it this way because that's not working. Oops. Okay, that the blue is showing regions where the control subjects have greater activation than the people with major depressive disorder, and the orange yellow is showing regions where there's greater activation in the depressed patients than the controls. And you can see that all these blue areas are part of this DSON, again, this dorsal lateral prefrontal cortex, rostral anterior cingulate, and the PAG. That whole system that I described is less activated in the depressed patients than in the healthy patients. While the amygdala, a region important for fear related, well, this is in response to pain, is more activated in the depressed patients than the healthy people. So there's interactions where even patients with other disorders can have abnormalities in the pain system that can lead to pain in these other disorders. So, okay, you've got all this, these changes, anatomical changes. Chronic pain patients don't just have pain. Unfortunately, once you've had pain for a long time, and this is where it gets kind of sketchy because you think, well, that person is also depressed, that person has anxiety disorder, so maybe that's really their, but the pain itself we're finding can in fact lead to some of these other disorders. And we also find that people with chronic pain report cognitive, they feel I can't remember things as well. And the experimental studies are showing that there are some cognitive changes. They're not huge, but there are clear cognitive deficits, particularly in memory tasks that involve distraction. So memory in the face of a distractor, that you're finding that people with chronic pain don't perform as well. This is one of these tasks, the ACT task, just showing it's not a huge effect, but it's significant that fibromyalgia patients don't perform as well as healthy matched controls. And many of the fibromyalgia patients report what they call fibro fog, and clinically report, I just don't remember things as well as I used to. But what we're finding is that some of these anatomical changes in the prefrontal cortex correlate with the performance on these cognitive tasks. So it might be that some of these comorbidities that start happening when somebody has chronic pain could be related to the changes in the brain that appear to be caused by the chronic pain. And I just want to point out, I talked about how with placebo that you actually can get this endogenous release of neurotransmitters that are important for pain control. Well, with chronic pain, we actually find that you can get all that you don't get as good a release of some of these important neurotransmitters as you do with healthy people with a pain challenge. So, for example, there are opiate receptors all over the brain, and they're not all important for pain, but there's some that seem to be in that when you give somebody a pain challenge, you release these opiate receptors, or release opiates at these receptors in parts of the anterior cingulate cortex, thalamus, and nucleus accumbens. And what people are finding is that patients, this is an example with fibromyalgia patients, there is reduced binding, there's reduced release of opiates in response to a painful stimulus in patients that have fibromyalgia than healthy people. And we found similar things with dopamine as well. So it looks like there's anatomical changes, there's changes in the way neurochemicals are released in the brain. So there's real things that are happening with chronic pain that you don't see in an acute pain situation. So I'm going to just reiterate what I said here and conclude and get back to Brian. And pain is a multidimensional experience that can be transformed from adaptive to a disease state. And now even pain researchers are even thinking of pain as almost like a neurodegenerative disease, as chronic pain is not the same as acute pain. Pain transmission involves peripheral, spinal, and forebrain processing. Pain perception is modulated from descending pathways that may have either facilitatory or inhibitory effects. Psychological state can have a profound effect on pain perception and associated neural activation. Neuroplastic alterations in the CNS can result in sensitization and an imbalance between modulatory descending, facilitatory, and inhibitory pathways. Long-term pain can alter brain anatomy and associated emotions and cognitive function. Chronic pain patients may have alterations in forebrain opiate systems. So that's it.
Thank you very much. So we have time for
You know,
some
questions on that before we get back to?
Is the loss of gray matter causal or an effect?
Well, we've now done, this has been, there's now multiple lines of evidence that it is effect. One thing is that there's evidence that the longer you've had the pain, the more gray matter you've lost. And also, there's now, we've done in animal models, longitudinal studies where we take rats and then we either assign them to a nerve injury group or a sham group, follow them over time, and in a rat, 4 or 5 months after the injury, we start seeing these same changes in the frontal cortex. And so these are genetically identical and environmentally identical animals. And interestingly, when we've done that, at about the same time we start seeing the changes in the frontal cortex, the rats start developing anxiety disorders. They had the injury for several months. In a rat's life, 5 months is a long time. They only live 2 years. At that same time, that if we do things like elevated plus maze, where tests of anxiety, they're starting to show anxiety then, but not until then. So there seems to be, that again, showing that maybe these anatomical changes could be leading to some of these other comorbidities. So there's more and more evidence that, but on the good side, we don't think it's all neuronal loss. We think it may be changes in synaptic connectivity and dendritic arborization, because there's now some evidence that you can reverse this if somebody's had chronic pain for a long time, and then, like, so for example, there's a study with osteoarthritis that after a hip replacement, the person no longer has pain, and then after a few months, you're getting some reversal of these anatomical changes. So that's why we're going back to the animal studies to try to understand these mechanisms. But more and more, it seems like there may be more of changes that are reversible and not total neural loss.
Does that apply to the gray matter also? In other words,
But that would be-
gray matter that's lost, is that
That's what I'm
eventually
talking about,
replaced?
the gray
Yeah.
matter. So in the human studies, the gray matter that's lost, there's been now 3 studies that show you can at least have partial reversal after successful treatment for pain. You know, these are kind of oddball cases. Most people with chronic pain, you can't treat it. But there are some cases where somebody, you know, for example, osteoarthritis that then has a joint replacement, then they could have had pain for years and then it's reversed.
But given the depression or the physical pain disappears, are there exercises, mental, that you could do to increase your gray matter after you've been through
Yes,
an
and I didn't
episode?
go to that, but we are actually looking, because being at the complementary alternative medicine, we're looking at some of the mind-body therapies. And even with aging, as we age, we lose gray matter, and that's really common. If you just take any group of MRIs like that, you'll see that. But we're finding that with yoga, we're seeing like a complete reversal of that. So you have the healthy people that are just going down with gray matter, and then people that are yoga practitioners, and they're maintaining that. And with meditation, and it hasn't been done with exercise, but we're looking at exercise because there's evidence that exercise can reduce in animals some of the, like you can have long-standing neuropathic pain that you can reduce. So I think that there are things that we do that improve, that reverse
How do you
these things.
quantify the changes in the gray matter?
I can't really, we can't I wouldn't be able to, well, we have cortical thickness. We can say the cortex is this thick in the area and it gets to be, but the changes we're talking about here are, 5% or something like that. This is not like total loss of your gray matter.
I'm curious, what is the ordinate of some of those? Is like 0.1, 0.2, 0.3? Is that thickness?
Okay, well, no, there's 2 different ways of doing this, and I showed some of this called voxel-based morphometry, and it's kind of an arbitrary measure. And some of the other measures are cortical thickness, but you can only do that in the cortex. So this VBM analysis, which gives you the total number of voxels that are present, of units that are present. So it's hard to kind of say what that is in centimeters or millimeters. But the cortical thickness, you actually can have that in micrometers. But then you can only do that in certain parts of the brain.
So is this integrated from 3-dimensional, like Z-frames?
Right. This is you do an MRI, which an MRI basically is a whole bunch of slices that's integrated into a 3-dimensional space.
want to say a few words about phantom limb?
I could say a few words. I wish I really understood it. It's, again, one of these situations where, I mean, there's some part that where and there's pain that can be coming from the stump, from the nerves, from a neuroma, but there are clearly cases where you're getting this representation and you're feeling the pain even though the input is no longer there. We don't really understand phantom limb per se, other than that you're having the same phenomenon, that you're activating the central pathways even though you no longer have the peripheral input. Do you have a...
Mind,
Yeah, what do you want to say about phantom limb?
Yeah, the other thing to keep in mind about phantom limbs is that it's not just pain, right?
Right.
That phantom limbs, the people that suffer them can actually move them. They actually feel like they can move those limbs. They feel like they can reach out and grab things. And if you were, say, having them hold a cup with their phantom limb and you move that cup quickly, they'll experience pain from moving that phantom limb's hold on that cup.
Right.
That they're much more complex than just, oh, I'm cut off and now I have this sensation that persists forever. They can make them do unnatural movements. So if you have a phantom limb, you can actually flip your wrist over in a fell swoop without turning your arm. You can actually make yourself do that with that phantom limb. You can experience that.
And some of the pain from phantom limb will be something like the person feels like their hand is in this cramped position, and that's what they feel, but they can't make themselves move the hand, so they continue to feel like it's cramped and it hurts. And there's a technique now, it's called the mirror therapy, that's shown, at least for some people, to work, that you have, so the person feels like my hand is cramped and I can't make it move. So then they put your other hand in a mirror, you put it in that same position, and it looks like it's the missing arm that you're feeling the phantom, and then you release your other hand, and you have the sensation that you've released it in the hand that feels like it's in the cramped position, you can't move. And even people that are born without limbs can have a phantom limb, and it can telescope, and you have it, and then so it's a very complicated body awareness.
Yeah, people even have supernumerary limbs where they grow other limbs out of strange places and feel like they have them. So it's an odd thing to talk about, I think, in the context of
I
what
think
we're
we
doing.
have to move along because the fire department's going to throw us out at 6 o'clock here.
Well, I'd like to introduce you to Melissa. All right. We'll just take a seat here. Melissa's been my patient now since 2004, we decided. Why don't you tell the audience here a bit about what you were like before you developed your symptoms and what those symptoms were like as they came on?
So before I started developing symptoms, I was very active, and I was still in college. I was an undergrad, and so very active, very involved in a lot of things. I graduated from college. My husband came out here to go to Georgetown graduate school. I came out here shortly after, and that's about the point in time when symptoms started to set in. I was, I think, 23, so I was very young, and instead of wanting to, go out and explore and do all the things, I moved here from a very small town in the Upper Peninsula of Michigan to Washington, D.C., so you'd think I'd be out, and excited doing lots of things, and I didn't want to do any of that. I was exhausted all the time, slept almost all the time, and I wasn't really aware of the pain initially. And at one point my husband said, "This isn't normal, this isn't right, something is wrong." And so that's when I went to go and see my general practitioner. And I was one of the fortunate ones because right away he said, "Well, we're going to do these other tests, but I think it's fibromyalgia." And I'm like, huh? It was very, it was not that well known at that point in time. And so he did all the tests and everything came back normal, and he said, "Okay, you need to find, someone who specializes in fibromyalgia." Well, at that point in time, I was working at the Georgetown Hospital, and so looked up, rheumatologists at Georgetown, and who happened to be working there, but Dr. Kloss. So I was very fortunate and just happened to be in the right place at the right time. and was able to go and see Dr. Claw and got a diagnosis immediately. Many people with fibromyalgia don't experience that immediate diagnosis. They go from doctor to doctor being told, oh, you're imagining it, it's not, it's all in your head. And I don't think it's that way anymore because fibromyalgia is much more known than it was back when I was diagnosed. I know people still run into that, but I think a little bit.
Do you think you can describe the pains that you have or how you experience your pain to the audience?
So for the most part, I always have a sort of burning sensation throughout my body. And actually, you'll see, things feel very heavy. So the microphone actually feels very, very heavy right now. There are times when if I'm flaring on a particular day, my hands will hurt. It'll be very difficult to write or type. Other times it'll be my neck and shoulders are just very stiff and feel almost like they're just one solid unit instead of moving parts. And so just, each day it kind of changes a little bit, but there's always an underlying kind of constant pain that stays there.
And so over the years you've had it, that felt like the pains have never really stayed, but they move and they shift on you.
Right.
Right? Have you ever been surprised by any of your pain?
I think initially when I was first diagnosed, because I didn't realize I had pain until Dr. Claw hit one of my tender points and I jumped off the table. That was probably about the only time I was surprised. Now it's more I've gotten used to it, and it's like, okay, well, here's another one,
So what other things do you feel besides pain that you've attributed to your fibromyalgia?
The other big component is fatigue. So that fatigue will just kind of come out of nowhere and knock me down. There's also the cognitive piece where I'll be talking and in the middle of a sentence and a thought and it just disappears. Or memory, things that, I've known for years, and at one point in time I'll just not, remember my own birthday. So,
When you explain a little bit more about the fatigue, because a lot of people think, we have appreciated fatigue in our lives or after exercise or something. What does it feel like when the fatigue comes?
when the fatigue comes, it's exhausting. So you feel, if you're laying down and you have to go to the bathroom, you find yourself laying there, and I have to talk myself into getting up off of the couch because it takes that much energy to sit myself up, stand myself up, and walk over to go to the bathroom. So, it's kind of an extra level of exhaustion.
Okay. Have you noticed anything else with your symptoms that you'd like to tell us about? Well, how has it affected your life? When this happened, you were in school, and you probably thought about going on a particular path. What has this done to how you live your life?
So, it's caused me to slow down on a certain level. Initially, definitely. The hardest thing was not being able to exercise and be as active as I was. And kind of mentally wrapping my mind around that and adjusting to I can't do things the way I always used to. I can't just get up and go and run and start running a mile when I want to get back into running. It just doesn't happen anymore. And so it took a period of my life to kind of adjust and learn how to live with the fibromyalgia. And then, I've though not let it get in my way. I've still, I've had kids, I've gone to graduate school, I've done, and continue to progress. I still work full time. So I try not to let it slow me down, but I've also learned to recognize how I'm feeling. So I learned how to adjust my activities, or and I try not to plan too many things too close together because I know it'll knock me down, and I can't afford to be down, for 2 weeks to recover.
What sort of things have you found over the course of your disorder that have been very helpful for you? What things have been really not helpful for you?
The most helpful thing has been really finding the right doctors and caretakers. I mean, that I think was a big reason why I've been able to work with the illness and continue to move forward and live my life. The other thing is also having a good support network at home. My husband's very supportive, my family's very supportive, and they understand. My little kids don't always understand, but when I'm not feeling well, my husband will step in and pick up my daughters instead of letting them climb on me. So having that support at home is very, very helpful. The challenges for me is not, the not knowing what is going on, what's caused this, there's no explanation, there's no quick fix for it, which is a challenge. So that, it's very frustrating not to have, be able to take a little pill and make it go away. It just doesn't happen that way.
Is there anything else that you think that the audience should know about your experience?
I think the biggest thing is just recognizing that there are a whole host of invisible illnesses is one of the new terms that, I don't look like I'm sick. I don't act like I'm sick. I've tried not to let it get in my way, and there are many, many people that are like me, but I do have my challenges. I do have, my limits. And so having doctors and researchers that understand that and help me to try to work through it and help the patients try to work through it is tremendous. I mean, that I think is what almost all fibromyalgia patients want, is just someone to say, okay, well, let's figure out how to make it work.
Have you run across a lot of stigma because of your symptoms? Do you feel like you need to hide them from people?
I have. There have been occasions where I've not gone around and advertised it, I guess. And you do run across some individuals where you say, oh yeah, I have fibromyalgia, and you get this look like, oh yeah, right, that's not real. But that was quite a while ago. I've noticed more in more recent years when I've said, yes, I have fibromyalgia. People know what it is now and tend to understand and are more curious about it. So I think that stigma is changing some.
Well, thank you so much, all right, for talking to us and letting us hear about your problem. And I'll finish up here. So here again, here's Melissa, right? And so what you get after talking to Melissa is that while fibromyalgia, which was initially characterized simply on the basis of pain, is so much more than just pain. Pain is a part of the experience, but there's a host of other sensations that come along with the pain, right? The tiredness, the mental fatigue and cognitive challenges that stand in the way of doing what you want to do. Right? There's almost a bondage of the body. The mind and the spirit may be willing, but the body is not cooperating. And so it reduces our options. It changes how we have to think about ourselves and our lives. And there's the sadness of loss that comes with that. Worse for some, not so much for Melissa, but for other patients that I have, the consequences of their illness distort their ability to have a normal life. Their disability from their symptoms erode their ability to have relationships. The ideas that they have about themselves when they were growing up, I'm going to be a good husband or wife, I'm going to be a good parent, I'm going to work and be a productive member of society, I'm going to have friends and socialize and do and be, that the symptoms get in the way of doing all the things that they're supposed to be. And the things that connect them to society start to break down as they stop working, they're unable to engage their friends in social activities, they're unable to provide as a parent, they're unable to be as supportive as they want to be as a loved one. And many patients describe this almost as an existential challenge. I've had many patients say that I almost feel like I'm a ghost in the world, that the world is going on around me, but I'm not able to participate in it. Right? And these are other aspects of fibromyalgia that really need to be considered, that it's more than just pain. Right? It affects every dimension of our lives. And I would say almost a better definition of fibromyalgia would be that it's really a constant state of perceived physical and existential suffering that occurs in the absence of physical causes that you can observe. Yes? So fibromyalgia has between a 3-to-1 to a 9-to-1 gender preference for women, the way that we measure it, right? However, if you look at different populations and different times, those numbers change. If you were to call it chronic widespread pain and do a male survey in England, the numbers come closer to 1-to-1. If you look at military and say that Gulf War illness and similar disorders are cousins of fibromyalgia, well, then it's all men. It depends on how you look at these things. Women tend to get counted more frequently than men in these kinds of studies, and they tend to use physicians for these problems more than in men. The true prevalence of this will only be shown as we do larger population studies. Yes? Right, it means pain of the muscular tissues, right? It used to be fibrositis, which was inflammation of the fibrous tissues, but it was thought to be an improper word and was switched. Oh, of course not. No. Outside of what Dr. Bushnell showed us, which shows that there are neurological changes in the brain in terms of its activation that can distinguish that there's differences in how pain and feeling is being processed. Looking at people with fibromyalgia, there's nothing to observe and there's nothing to measure. Where you're going into is the world of lumping and splitting, right? And lumping and splitting is a perspective issue. Considering that we define it simply by its symptoms and not by any physiological aspects to date, at this time, yes. We're going to get to that in a second. It's always going to be controversial, right? I think in medicine now, what has been accepted is that the suffering is real, right? Nobody is saying that people are inventing the suffering. The initial controversies were really about, is this factitious? Are people making it up? I don't think anybody's arguing about that. But the arguments become whether this is a process that is related to a particular neurologic phenomenon or disease, or if this is more of a social cultural construct that has many more dimensions that are shaping and creating these experiences. All right. Well, we'll get there. All right. So fibromyalgia, as presented in this picture, this is how we thought about it in 1990, where we only defined it in terms of pain and tenderness. Over the 20 years or 23 years since it was first defined for research purposes, our understanding of it has changed. And what we've come to quickly learn, back even as early as '81, is that fibromyalgia is not just pain. When we look at people who have the disorder, about 86% of them will talk about this profound fatigue, About 78 have a non-restorative sleep sensation that they get. Anxiety in 2/3, depression in 1/3, memory issues between 70% to 40%, headaches, dysmenorrhea, irritable bowel symptoms, and the list really goes on and on. That there is a wide array of somatoform sensations that come along with fibromyalgia. We call it fibromyalgia because pain brings them into the office, but pain is not the only part of what it is. And in 2010, it's been reclassified in the new consensus criteria, where pain is clearly a large part of what fibromyalgia is, as you can see here in these upper pieces here, these questions. But now fatigue, unrefreshing sleep, and cognitive symptoms, and even a physician's impression of the severity of other somatoform sensations have now entered the diagnostic schema for reasons that people argue about. But what this really means is that our concept of what fibromyalgia is has gone from being this prototypical functional pain disorder now to sort of a multi-symptom disorder where pain is one, if not the most prominent, of a group of symptoms. So fibromyalgia is no longer just pain. And so one has to wonder if we approach fibromyalgia as a pain disorder, will we succeed in its treatment? And one of the things that Catherine had brought up is this concept of central sensitization, the increase in excitability of the central nervous system, that normal inputs are exaggerated, which there is evidence of in fibromyalgia. The question really, the real $1,000, $100,000 question, actually there's probably $100 billion question, is can we successfully treat fibromyalgia by targeting these processes that are part of central sensitization? And so that's going on right now. I just need to turn on your television and you'll see the advertising for these three medications. Pregabalin or Lyrica is a medication that's been on the market, I think, since the late 90s. It's thought to work by interacting with the alpha to delta subunit on calcium channels that exist in neurons, and its effects on them diminish their excitability, and so is thought to reduce central sensitization by reducing nervous excitability. It was initially an anticonvulsant, which in their testing they discovered that it had analgesic properties. Duloxetine, which is Cymbalta, and milnacipran, which is Savella, are this class of drugs called the serotonin norepinephrine reuptake inhibitors, or SNRI drugs that Dr. Bushnell discussed. These work by preventing neurons from taking back up serotonin and norepinephrine that they release, causing it to linger on longer in the synapses and extending their effects on nerves. Serotonin and norepinephrine are thought to, again, dampen down nervous responsiveness and hence address the issue of central sensitization. And so these drugs have been put into trials for fibromyalgia, and the gold standard for determining whether a drug works is the double-blind placebo-controlled trial. I'm not sure if all of you are familiar with its methodology, so I'll review it in brief here. You start with a population of interest. This is fibromyalgia, and you basically have the pool of everybody. But when you're doing clinical trials, you've got to be a little bit more picky. You have to choose the people that are going to come, which is already reducing your pie a large bit. And plus, for clinical trials, you want to get them to be as similar as possible. You want to make sure that they're not taking other medications that might interfere with the results. So in fibromyalgia trials, they have to be able to come off their medications and not take anything for the extent of the trial besides the trial drugs. They also can't have other problems, large medical issues, concomitant arthritis. They can't have psychiatric issues or be overtly depressed or anxious, which are issues that come along with fibromyalgia. And so in the trials that they performed, they really had a cherry-picked group of fibromyalgia patients that they put through the ropes here. So what you do is you take the people that enroll, you measure them at baseline, and then you randomize them to either receive the treatment drug or a placebo compound. And they do this in a double-blind way, which means that neither the patients nor the physicians administering the drug have any idea of what's being given. So nobody knows what they're getting, but they take it for the length of the trial, And then at the end, you measure how they did. Then you take the baseline measurements and you compare them to the final measurements and see what the changes are. And then you can compare the two arms to each other to determine if those results are different depending on the therapy. This is how we do it here in America. And this is what we find. And so these are the results of the 13-week pregabalin study. What you see here at the top is that they all start on a scale of 0 to 10 on a pain scale, or around a 7 of bodily pain. The placebo group, over the 13 weeks, gets a little bit better. They improve about a full point on a scale of 1 to 10. This is different from the pregabalin groups that change about 2 points over that period of time. And most of those results are statistically significant differences between the groups. It's important to keep in mind that what's a meaningful difference in pain? We know that if I went from having a pain of 7 to having a pain of 6, I would not be cheering. I may be a little happy about it, but I wouldn't feel cured. There's been a lot of talk about this, and Dworkin's work with impact has sort of defined 2-point change in pain as a minimally clinically important difference. So if you change around 2 points, you meet the standard of that difference having actually a clinical impact. And so this study shows that A, there is a difference between placebo and drug action, and B, it meets this sort of standard of a 2-point change that meets the minimally clinically important difference. And then we look at duloxetine and milnacipran, and lo and behold, they're exactly the same. The results, again, placebo changes about 1 point, these medications change around 2 points. And based on this data, done in 2 trials, the FDA approved these drugs. So, do they work? Well, immediately, these drugs started being advertised. And you can see on TV that the advertisements are almost always of women. They're always middle class, they're always attractive, always working, or running families, because that's what they want the image to be of these medications, the potential for treatment. And they spend a lot of money to do this. Just back in 2008, for the first 3 quarters of the year, they spent $253 million. During that same year, it was worth it for them because they brought in about $600 million in sales of these medications. And so this is not a little bit of money. And the question is, well, do they really work? Are they worth it? And so when we do double-blind placebo-controlled trials, these are small groups. And small groups have wide confidence intervals. You can't be sure that what you're measuring is exactly right. It falls between 95% confidence intervals, somewhere along those lines. And so a better way to get an understanding of how well drugs work are to take all the results and combine them together. And this is called meta-analysis. And in meta-analysis, you take all the studies done with a particular medication, you squish them together, and those combined results you then report. And this is a forest diagram of what a meta-analysis looks like. Here's all the different studies on the y-axis, and this is effect size. So no effect is 0, this line in the middle, and then positive and negative effects can see on either way of that line. And this is an individual study. This is the actual effect they report, and this is the confidence intervals that we know that the effect probably falls between. Larger studies have smaller intervals because they had more patients and you can feel more accurate about what they found. And smaller studies have really wide intervals because they didn't do enough people to feel confident about their results. And so what happens when we look at these medications in this way? And so my colleague Winfried Hauser did some work, a number of these analyses looking at pregabalin, and him and I together have a submitted paper to the Cochrane Review, which does this masterfully, to look at whether these drugs are working. And here's our forest plot. And you can see that line of no effect. And you can see they are on the side of effect, but not a whole lot. Right? They come real close to that line. And when you look a little closer, you do some analyses, you realize that the effect of pain, when measured through something called the Cohen's d, is small. Right? It's not no effect in these studies, but it's a very small effect. It's not a moderate effect. It's not a large effect. The effect on pain is small. When we look at other dimensions of fibromyalgia like fatigue, sleep, cognition, anxiety, depression, these don't change with these medications, only a small effect on pain. More importantly, you can calculate the number of people that you actually need to give the drug to have a good effect. All right, so you need to treat, in terms of pregabalin, 12 people to have one person to have a positive result. All right, that's the number needed to treat. The same token, you can look at the number of side effects that happen during a study, and it turns out that you need to treat 12 people to have one major side effect from taking this medication. And so the meta-analysis suggests, well, the benefits of these medications in terms of pain is small, and the benefits seem to be equal to the amount of chance of harming somebody by trying these drugs. And you've got to treat a whole lot of people before you see real benefit. But how about the SNRI class? Well, this is our Cochrane review, part of this project here. And again, here you see your forest plot. We're seeing a effect size about a little bit better than we saw with the pregabalin. But again, a very small effect on pain, and the numbers needed to treat are not really that much better. We need to treat 11 people with the SNRI class to have a positive effect, and 11 to have a side effect. So the meta-analysis don't say that they don't work, but they suggest, well, maybe they don't work very well, and you need to treat a lot of people to find benefit, and the likelihood of harm is not insignificant. But that doesn't tell us a lot. We already talked about that the people that were in these trials are cherry-picked. They don't represent the general population, people that couldn't come off their meds, people with other problems. And to understand whether these things are helpful, we need to look at how they actually work in a population of people with fibromyalgia that are not pre-selected. Just what does it look like in the general population? And this year, we published a study that looked at this, where we took a population through the National Data Bank of Rheumatic Disease with Fred Wolf. We took 3,100 patients and followed them over 11 years, and which was like 19,000 reports, where we measured all the medications they took and a number of outcome measurements over the course of the entire study. And what was interesting for us is that these new medications were introduced about halfway through our study. And so when 2005 rolls around, these medications come on the market, and we can actually watch the trends of their use in this population, and we can see if their adaptation altered outcomes. And so let's see what we see. So first, this is looking at non-steroidal anti-inflammatories and opiates. And you can see here that non-steroidal anti-inflammatories have never been shown to be helpful in fibromyalgia and are known to cause harm. And over the 11 years, their use has fallen off a significant amount. However, opiate use hasn't changed a bit over the 11 years. This is looking at the medications that we're interested in. This line here is pregabalin. So anticonvulsants were used about 8% in 2000. They're a little bit under 30% used by 2011. You can see that the approvals for the SNRI class of drugs started around 2003, where you have about 20% of people by 2011 taking these drugs. 40% of our population were taking one or the other, and 50% of the patients were on some sort of CNS acting drug by the end of the study. So how did it work? So this is 3 lines: pain, fatigue, and physical function. As you can see here, these lines are straight and flat. Right? The introduction of these medications did not alter the outcomes that we care about at all in fibromyalgia. In fact, looking really closely, what we do see is that there is a small effect on pain that you can discern with the use of these medications. If you're taking one of the new drugs, your difference in pain compared to people not taking one of the new drugs is about 0.17 on the scale of 1 to 10. If you're taking more than one of these drugs, it's about 0.23 on a scale of 1 to 10. This clearly doesn't meet that standard of a meaningful, clinically important difference. And so you can see that depending on how you look, the drugs kind of work or they don't work. Right. And if you recall Melissa's story, the things that matter most for many fibromyalgia patients are not what we prescribe them, but the circumstances of their lives, their approach to their disease, and their support and family that are there to understand and help them through. And so to conclude, functional pain disorders encompass a wide array of common disabling syndromes that we deal with in medicine. The evidence does suggest that functional pain disorders do share common neurologic underpinnings, as described by Catherine. However, to date, our attempts to target these systems with medication, which admittedly is in our infancy in doing, because we're not even sure if we're truly doing it properly, but our attempts have been not particularly effective to date. And with that, I conclude, and thank you for your attention.
Hi, do we understand the physiological basis of fatigue?
No.
But it seems to be a component of lots of chronic pain syndromes. Is that?
The big difference between pain and fatigue is that pain has a wonderfully elucidated pathway that was painstakingly mapped out over the course of, I think, 40 or 50 years. There is no known system for fatigue. We have no idea what chemical substrates lead to fatigue. We have no idea what parts of the body are sensitive to measuring fatigue, and we don't know. We all experience it, right? You know, everybody knows what it's like to be tired, and everybody knows what it's like to be really tired, at least once or twice in their life. We know it's a real experience, but just because we know it's real doesn't mean we know how to describe it at all. And fatigue, in some ways, is in the doldrums because we don't really have any physiological grasp of it. All the starts and stops we've made to try to understand it are baffling. People for a long time thought lactic acid, changes in pH, all these things that muscles release when you work them out vigorously were the cause of fatigue. But it turns out they actually improve muscle efficiency, that it's a dynamic system that improves how we function over time as opposed to creating the sensations of fatigue. And so, we have no idea. That's really at the end of the day. Yes?
You mentioned that fibromyalgia has many associated things, listed a whole list there. Mm-hmm. Do people ever have fibromyalgia without having the pain, but they have a array of these other symptoms?
Right, so this is lumping and splitting. All right? You can't have fibromyalgia if you don't have pain. But we have lots of other names for you, depending on what you complain about. If you say that you have fatigue more than pain, you're in line to become a chronic fatigue patient. There's all sorts of other ways that we slice it. The complaint that predominates your existence is how you end up being named, which has nothing to do with your physiology.
So the medications haven't done that much. And Melissa, was it? Your life support changes and all that are extremely helpful. I wonder if you or anyone here has other hunches about what else to do. For example, yoga was mentioned, meditation. What other sort of lifestyle changes could be helpful to fibromyalgia patients?
So the party line is a multimodal therapy, which is the use of cognitive behavioral therapy to help you come to terms with and gain control over your sensory experience. Aerobic exercise to keep you vital and to help with whatever exercise helps with, because it's good for everything. And the judicious use of medication to help deal with symptoms so that you can do these other things that you need to do to have a life. To rely on medications to be the central pillar of your treatment strategy is one that most often fails. However, even when you do all these things, these are not curative, right? And what we see when we look at people over time is that they do lead to some improvement, but nobody really becomes normal again once they develop these symptoms, except for the rare few. Right? And there's no way to predict that if I do these things for you, that I can return you to the life you had before you developed your symptoms.
Sure. I can tell you, so from my experience, and Dr. Walitt knows this very well, I don't like to take medication, so he knows when I'm really bad when I show up in his office asking for something. And I have found actually when I've done yoga, it's very beneficial, and massage. Regular massage is the one thing that I've found that helps me maintain my symptoms. And it's a regular thing. I have to go once a month, and it just kind of gives my body that time to, relax and release and, kind of regroup and recharge, whatever you want to call it. But a lot of the alternative lifestyle things I have found to be very beneficial, much more so than the medication.
One of the problems you encounter, though, is that for every person that has a wonderful experience with massage or acupuncture or yoga or modality, there's somebody who's like, if they lay hands on me on that massage table, they push me off the roof. They can't touch me. Or if they push those needles in me, it does me in, but I'm okay with the massage. A great deal of the treatment of fibromyalgia is ultimately an empiric trial. People have to take the time to know themselves and to experiment with different things to find things that they find helpful. You can't predict before you test what's going to be helpful. But trying everything or going to extreme lengths and always chasing the dream of a cure is ultimately defeating as well. And so you have to sort of walk this balance between trying things and not getting carried away. And it's very difficult for patients, I think.
I think, unfortunately, we have to end, but if you wish to converse. But I want to thank you all very, very much. And it's wonderful to know that the NIH is going to heavily invest in bridging some solid neuroscience into a very complicated clinical group of disorders. So thank you again. Thank you.